I want you to imagine, for just a second, taking your car to a mechanic.
Okay, I'm picturing it. Never a fun trip.
Right. Let's say you're going in for, just a routine oil change, nothing major. So you drop the car off, you walk down the street to grab a coffee or whatever, and when you come back an hour later, the mechanic looks at you from across the counter and says, well, good news and bad news.
Oh no, that's the last thing you want to hear.
Exactly. So he says, the good news is your oil is changed. The bad news is, while I was doing it, I accidentally dropped a wrench into the engine block, completely smashed your radiator, and totally ruined your alternator.
Wow. Okay, so a disaster.
A total disaster. But then he says, don't worry, I went ahead and replaced the radiator and the alternator for you. Oh, and I'm going to need to bill you for those parts, plus, the extra 5 hours of labor it took to fix the damage I just caused.
Yeah, I mean, you would be absolutely furious.
You would refuse to pay. You might even call the police or, I don't know, the Better Business Bureau. You certainly wouldn't pull out your credit card and happily pay a premium for fixing the catastrophic damage they themselves caused.
Right, you just wouldn't do it.
But what if I told you that until very recently, this was exactly how the United States healthcare system operated when it came to patient safety?
It almost sounds like hyperbole when you frame it around a broken radiator. But that is the precise economic reality we functioned under for decades.
Really? Exactly like that?
Basically, yeah. I mean, a patient would go into a hospital for a routine surgery, acquire a life-threatening infection because of, say, a sterile protocol failure within the facility itself.
Okay.
And the hospital would simply generate a new massive bill for the extended ICU stay and the expensive antibiotics required to treat the infection they caused.
So they were getting paid extra to fix their own mistakes.
Exactly. The hospital was financially rewarded for the extra treatment required to fix its own preventable errors.
Okay, let's unpack this, because today, the whole mission of this deep dive is to decode this massive, hidden economic machine.
The big one.
It really is. We're going to look at how the healthcare system actually tries to stop accidental deaths and perhaps a bit more uncomfortably, how it mathematically decides what a human life is worth in dollars and cents.
Which is a heavy topic, but so necessary to understand.
Right. And we're drawing on two incredibly dense but absolutely vital sources today. First, we have a 2021 presentation by Barbara J. DuPont titled The DNP and Quality Improvement DMP's Worst Nightmare.
Great title.
Yeah, it's very catchy. And that's going to serve as our ultimate glossary for the critical underlying terms of healthcare economics. Second, we're diving deep into Chapter 9 from the Waxman text, which is called Ensuring Quality Care While Controlling Costs.
Both are essential reading if you really want to understand the modern medical landscape.
Definitely. By the time we are done today, you are going to understand the hidden gears turning behind every single hospital visit you make. You'll see why quality in healthcare isn't just, some corporate buzzword printed on a poster in the waiting room.
Right, it's way more than that.
It is a multi-billion-dollar survival metric that dictates whether a hospital actually keeps its doors open.
But before we can begin to analyze how those multi-billion-dollar gears turn today, we really have to look at the horrifying catalyst that forced the entire system to rethink its basic operation.
The wake-up call.
Exactly. We had to examine the wake-up call. Because the system had operated in this state of, basically willful blindness for a very long time. And a specific moment forced the blindfold off.
Yeah, because you can't fix a machine until you admit it's broken. And the moment the healthcare industry collectively realized the sheer scale of its dysfunction happened in 1999.
That was a huge year for healthcare quality.
Massive. There was this landmark report released by the Institute of Medicine, which is now known as the National Academy of Medicine. And the report had a very poetic, but honestly chilling title, To Err is Human.
It's a famous report for a reason.
The statistics buried in this report still take my breath away when I read them today. I mean, we aren't talking about a few isolated malpractice cases here.
No, not at all. The numbers presented in that document fundamentally shattered the public's perception of medical safety. The report revealed that between 44,000 and 98,000 people were dying in United States hospitals every single year.
Just pause on that. Up to 98,000 people.
Yes. And the critical context of that statistic is the actual cause of death. These were not terminal cancer patients. These were not individuals succumbing to, inevitable physiological decline.
Right. They weren't just naturally passing away.
Exactly. These were deaths resulting directly from preventable medical errors.
That's the equivalent of a packed, massive college football stadium of people just disappearing from the earth every 12 months because of mistakes. It's staggering.
It really is.
And when we say preventable errors, I think we need to be clear about what that actually looks like. We're talking about a patient coming in for, like, a knee replacement, but falling out of their bed during recovery, fracturing their skull, and dying.
Right. Or a patient getting the wrong dosage of a blood thinner because a decimal point was moved on a paper chart, which then leads to a fatal hemorrhage.
Or acquiring a severe pressure ulcer, what we commonly call a bed sore, because there wasn't a protocol in place to turn the patient every 2 hours.
And that leads to a bone-deep infection and sepsis. The historical context here loops right back to your mechanic analogy from earlier.
How so?
Well, up until the last couple of decades, insurance companies and the Centers for Medicare and Medicaid Services, which, by the way, we'll just refer to broadly as CMS from here on out, they were operating on a fee-for-service model.
Fee-for-service, meaning they paid for every individual thing that was done.
Exactly. They paid for volume, they paid for actions, they did not pay for outcome.
Okay, I see where this is going.
So if a patient developed that severe pressure ulcer we just mentioned, the hospital simply billed the insurer for the surgical debridement of the wound, the specialty dressings, the extended weeks in a hospital bed.
Oh my God.
Yeah. The financial sting of the error was passed entirely to the payer and the patient, while the hospital's revenue actually increased.
It's just like a high-end restaurant getting a Michelin star, but also getting paid a premium when they accidentally give you severe food poisoning because, well, they have a monopoly on selling you the antidote.
That's a perfect way to describe it.
It's absolute madness when you look at it structurally. I mean, I have to ask, how on earth did an industry filled with highly educated, well-intentioned professionals, brilliant surgeons, dedicated nurses, highly trained administrators allow this massive blind spot to exist for so long?
Well, what's fascinating here is that the root of the problem wasn't malice or a lack of individual competence. It was a structural void.
A structural void.
Yes, the system was designed by default, not by intent, to reward volume over value. You were compensated for the number of procedures you performed, not for the long-term health of the patient you performed them on.
Wow. Okay, so how did they pivot?
That realization is what prompted a vital follow-up report in 2001 called Crossing the Quality Chasm. The authors of this report looked at the landscape and declared that there is a massive gap, a literal chasm, between the healthcare we could theoretically provide based on modern science and the healthcare patients were actually receiving on the floor of a standard hospital.
That 2001 report did something really important, though. It actually gave us a working definition of what quality means, because quality is one of those slippery words that, it feels entirely subjective until you were forced to measure it.
It is very subjective usually.
Right. If you ask 10 people what a quality hospital stay looks like, someone might say it's having a private room with a nice view, while another might say it's having a doctor with a good bedside manner.
The National Academy of Medicine had to strip all that subjectivity away. They defined quality as, and this is a quote, the degree to which health services for individuals and populations increase the likelihood of desired health outcomes and are consistent with current professional knowledge.
Let me just translate that from academic speak into everyday English. It basically means, are your treatments actually making people better, and are you doing it using the absolute best, most current science we have available right now?
That is the perfect translation. And to make that academic definition actionable on a hospital floor, the 2001 report laid out 6 very specific aims for care.
The 6 aims.
Yes. They stated unequivocally that moving forward, healthcare must be safe, effective, patient-centered, timely, efficient, and equitable.
I want to spend a minute on those 6 aims, because they aren't just bullet points in a textbook. They are the foundation of everything we're going to talk about today.
They absolutely are.
So safe means avoiding injury to patients from the care that is intended to help them. Effective means aligning care with scientific knowledge, avoiding the underuse of things that work and the overuse of things that don't.
Right. Patient-centered means providing care that is respectful of and responsive to individual patient preferences, needs, and values. Timely means reducing waits and sometimes harmful delays for both those who receive and those who give care.
And then efficient means avoiding waste, waste of equipment, supplies, ideas, and energy. And finally, equitable means providing care that does not vary in quality because of personal characteristics, such as gender, ethnicity, geographic location, or socioeconomic status.
Those 6 aims served as a total shock to the educational system of healthcare professionals. Let's look at how this rewired the training of frontline staff.
Okay, let's look at that.
The Waxman text details the American Association of Colleges of Nursing, the AACN, and their core competencies for nursing education. If you analyze domains 5 through 10 of those modern competencies, you witness a complete paradigm shift driven directly by that quality chasm report.
Let's compare the before and after then. What were nursing students learning before 1999 versus what these new domains required them to learn?
Historically, nursing and medical education focused hyper-specifically on individual clinical skills and physiological knowledge. Could you successfully start an intravenous line on the first try? Did you know the precise cellular pathophysiology of congestive heart failure?
Could you push the right medication during a cardiac code?
Exactly. It was all about the individual practitioner's technical perfection.
Which is important. I mean, I certainly want the person putting a needle in my arm to have flawless technical skill.
Oh, absolutely. But domains 5 through 10 introduced a completely new reality: systems-based practice and improvement science.
Systems-based practice.
Yes. The educational leaders realized that a brilliant, perfectly trained, well-rested nurse can still administer a fatal dose of medication if the system they are working in is flawed.
Give me an example of that.
Well, if two medications with entirely different uses are packaged in identical vials and stored next to each other in the supply room, human error is inevitable, regardless of the nurse's clinical skill.
Oh, wow. Yeah, I can totally see how someone rushing during an emergency could just grab the wrong one if they look exactly the same.
Precisely. So Domain 5 explicitly makes quality and safety core values of the profession. Domain 7 requires nurses to respond to and lead within complex systems. Nurses are no longer just trained as clinical practitioners, they really have to act as systems engineers.
That's a huge shift in responsibility.
It is. They are required to understand informatics, data analysis, interprofessional communication, and how to proactively coordinate resources to build defensive walls against systemic errors.
So we have established that the system was catastrophically broken. The to err is human report rings the alarm bell. The quality chasm report provides the 6 goals to aim for.
Right.
But who actually drafts the blueprint for fixing it? I mean, it's one thing to say we need to be safer and more efficient. It is an entirely different undertaking to change the daily habits of a multi-trillion-dollar industry operating across thousands of independent hospitals.
Bringing about that level of transformation required intellectual heavyweights. That introduces us to the architects of quality. In the healthcare space, 2 names really tower above the rest: Avedis Donabedian and Dr. W. Edwards Deming.
Let's start with Donabedian. I kept seeing his name referenced in the DuPont presentation. He is essentially considered the founding father of modern quality assessment in healthcare, right?
He is. Donabedian revolutionized how we evaluate medical care by offering a deceptively simple but incredibly powerful tripartite model. He argued that you can only assess the quality of care by looking at 3 distinct interconnected elements: structure, process, and outcome.
Structure, process, and outcome. I think we need a really concrete example to show how these 3 things actually link together in the real world.
Sure. Let's use the prevention of a central line-associated bloodstream infection, often abbreviated as a CLAP-SI.
Just really quick, for those who might not know, a central line is a large catheter placed into a major vein in the neck or chest to deliver medications, right?
Exactly. And if bacteria get into that line, the patient can develop life-threatening sepsis.
Okay, so if we apply Donabedian's model to preventing that infection, what is the structure?
Structure encompasses all the raw resources and the physical environment. It is the foundation. In this scenario, the structure includes having an adequate ratio of nurses to patients so the nurse isn't rushed.
Makes sense.
It also includes the hospital supply chain, ensuring that sterile barrier precautions, full-body drapes, sterile gloves, masks, and chlorhexidine antiseptic swabs are physically stocked and available in the supply closet on that specific floor. Structure is the static environment.
Got it. So I have the gloves, I have the antiseptic, I have the time. What is the process?
Process is the actual delivery of care. It is the dynamic action. It's whether the doctor or nurse actually washes their hands properly. It is the strict, step-by-step adherence to the sterile protocol when inserting that central line.
So did they use the swab for the right amount of time?
Exactly. Did they use the chlorhexidine swab on the patient's skin for the required amount of time before making the puncture? Did they maintain a sterile field? Or did they accidentally brush their glove against a non-sterile bed rail and proceed anyway? Process is how the structure is utilized.
And that leads us to the outcome, which is the ultimate consequence of those first 2 steps.
Precisely. The outcome is the end result for the patient. In this case, does the patient remain infection-free, or do they develop a 104-degree fever and positive blood cultures 3 days after the line is placed?
So they're all tied together.
Yes. Donabedian theorized that good structure increases the likelihood of good processes, and good processes increase the likelihood of good outcomes. You simply cannot consistently achieve good outcomes without the other two in place.
Now, the Waxman chapter mentions that Donabedian didn't stop there. He expanded this into 7 specific pillars of quality to give administrators a way to measure every aspect of care.
The 7 pillars, yes.
The pillars are efficacy, effectiveness, efficiency, optimality, acceptability, legitimacy, and equity. I want to clarify a couple of these because they sound like synonyms. What is the real difference between efficacy and effectiveness?
It is a crucial distinction in medical science. Efficacy refers to how well a treatment or intervention works under ideal, highly controlled conditions.
Like a lab setting.
In a pristine clinical trial setting, where a drug is given to a carefully selected group of healthy volunteers with a very specific diagnosis. Effectiveness, on the other hand, is how well that same treatment works in the messy reality of the real world. How does it perform on a general hospital floor, given to a patient who might have 3 other chronic conditions, and who might occasionally, forget to take a dose? A drug can have high efficacy in a lab, but low effectiveness in the real world.
That makes total sense. And what about legitimacy versus acceptability?
Acceptability is viewed from the individual patient's perspective. Does this treatment align with the patient's personal preferences, comfort levels, and values? Will they accept it?
Okay. And legitimacy?
Legitimacy is viewed from a macro societal perspective. Does the broader community view the care as socially acceptable and ethically sound? Donabedian's framework translates perfectly into modern practices. If you look at the nursing role effectiveness model developed in the late 90s, it is drawn directly from Donabedian.
How so?
It connects the structural elements, like a nurse's education level and years of experience, directly to the processes of care they deliver, and finally to the clinical outcomes of their patients.
So Donabedian gives us the lens to see and categorize quality. But we need a mechanism to actually create it. Which brings us to the second architect, Dr. W. Edwards Deming.
Yes, Deming.
His name is ubiquitous when you study how massive industries, from auto manufacturing to software development to healthcare, improve their daily operations.
Dr. Deming is the undisputed father of modern quality control. He popularized an iterative 4-step management method that is the absolute bedrock of process improvement today. Originally, he referred to it as the PDCA cycle: plan, do, check, act.
Let's break down the mechanics of this cycle. Say a hospital realizes their patients are falling on the way to the bathroom at an unacceptable rate. How does the plan, do, check, act cycle actually fix that?
First, you plan. A team gets together, looks at the data, identifies the root cause of the falls, and develops a proposed solution. Perhaps implementing a protocol where every high-risk patient receives non-slip socks upon admission and an alarm is placed on their bed.
Okay, so that's the plan.
Second, you do. You implement this new protocol on a small scale, perhaps on just one specific hospital wing.
You don't just roll it out everywhere at once.
Never. Third, you check. You gather the data over a few weeks. Did the fall rate decrease on that wing compared to the baseline?
And then act.
Right. Fourth, you act. If the data shows the socks and alarms worked, you act to standardize that process across the entire hospital. If it failed, you act by adjusting the plan and starting the cycle all over again.
But the Waxman text highlights a really interesting evolution in Deming's thinking. Later in his career, he fundamentally altered the cycle. He changed PDCA to PDSA. He swapped the word check for study, plan, do, study, act.
He did.
That feels like a semantic difference, but I get the sense it was philosophically massive.
That's a monumental shift in organizational psychology. Deming grew intensely frustrated with how companies were implementing the check phase. He felt the check had devolved into mere inspection.
Like just checking a box.
Exactly. It evoked the image of an auditor with a clipboard, walking the floor, looking at a nurse, and simply checking a box to say, yes, the non-slip socks were on the patient. It became about blind compliance. Study, on the other hand, implies deep, critical analysis.
So study asks the harder questions. It's not just did they wear the socks. It asks, why didn't they wear the socks?
Yes. A study phase might reveal that the nurses aren't putting the non-slip socks on the patients because the supply room that stocks those socks is located 3 floors down.
Oh, wow.
And the nurses simply don't have the time to leave their unit to go get them. The study phase uncovers the systemic barrier. It's not about punishing the staff for noncompliance. It's about comprehending the friction in the process.
And this PDSA cycle is specifically designed to minimize disruption, right? There is a mantra mentioned in the readings that I found brilliant for its simplicity. One nurse, one patient, one day.
That is the golden rule of modern healthcare quality improvement. The goal is to test potential changes on the absolute smallest scale possible before proving the concept works.
So you don't just draft a memo and expect 500 nurses to change their habits overnight.
You do not rewrite a complex hospital-wide protocol for 500 beds based on a theory. You find one willing nurse, you apply the new process to one single patient for one single shift. You see what goes wrong, you study the friction points, you act on those findings to refine the process, and then you gradually expand the scope.
Let me play the skeptic for a moment, thinking about the listener who actually works in this incredibly demanding field.
Please do.
If I'm a frontline nurse and I am already exhausted from a chaotic 12-hour shift, we are short-staffed, my feet are killing me, I'm trying to manage 5 patients at once, isn't this Plando Study Act cycle just another layer of corporate bureaucracy?
It can certainly feel that way.
Doesn't it just feel like hospital administration handing me more paperwork and theoretical tasks that keep me away from actually laying hands on my patients?
The skepticism you are articulating is the single highest hurdle that healthcare leadership faces today. When improvement strategies are dictated from an executive boardroom and handed down as rigid mandates, they absolutely feel like oppressive bureaucracy.
So how do you get past that?
That is why the psychological concept of WIFM, an acronym standing for What's in it for me, is essential. You cannot simply command a stretched thin, burned-out workforce to adopt new habits. You have to generate authentic buy-in by clearly demonstrating the functional why behind the change.
You have to prove that this new process isn't just about protecting the hospital's legal liability or hitting some arbitrary regulatory benchmark. You have to show that it will actively make the nurses' shift smoother or unequivocally keep their specific patients safer.
If a PDSA cycle is executed correctly, the frontline staff aren't just the subjects of the experiment. They are the lead investigators.
Oh, I like that.
If you start small and actively involve the nurses and technicians in the study and act phases, asking them for their direct feedback on why a new IV dressing is difficult to apply, they become the champions of the change because they helped engineer it. They understand the rationale.
That makes total sense at the micro level of a single hospital floor. But relying purely on the goodwill, patience, and energy of an already exhausted workforce is never going to be enough to rapidly overhaul an entire entrenched national industry.
No, it's not.
Which brings us to the leverage point. Understanding the elegant theories of quality, like PDSA and Donabedian's pillars, is fascinating. But nothing fundamentally alters the behavior of a massive industry faster than holding its wallet hostage.
Now we're getting to the real mechanics of change.
Right. How did the regulatory bodies actually force hospitals to take these theories out of the textbooks and implement them on the floor?
They force compliance by fundamentally rewiring the flow of money. We witnessed a monumental transition from the historical fee-for-service model, which, as we discussed, rewarded the volume of care and inadvertently subsidized mistakes, to pay for performance and value-based programs. The government decided to weaponize its purchasing power.
Follow the money. It always comes down to following the money. So how did the regulatory bodies start turning the financial screws on these hospitals?
One of the most aggressive and impactful early maneuvers involved the creation of a concept known as never events. In 2001, Dr. Ken Kaiser, who was the former CEO of the National Quality Forum of the NQF, introduced this terminology.
Never events.
Never events. Events are defined as medical errors that are serious, unambiguous, and, most importantly, entirely preventable through the use of evidence-based guidelines.
The name is incredibly blunt. These are catastrophic failures that should literally never occur in a functioning facility.
The NQF meticulously defined 27 specific types of these events, grouping them across 6 categories: surgical, product or device, patient protection, care management, environmental, and criminal events.
What are some examples?
We are talking about nightmare scenarios. Leaving a surgical sponge or a metal instrument inside a patient's abdominal cavity after closing an incision. Performing surgery on the wrong body part, like amputating the left leg when the chart clearly stated the right leg. Or a patient dying because a hospital pharmacy dispensed the wrong medication.
I remember seeing the shift in hospitals regarding wrong site surgery. It's why today, before you go under anesthesia, the surgeon will actually come in with a Sharpie marker and physically sign their initials on the exact knee they're supposed to operate on.
Exactly. It's a direct result of trying to prevent never events.
But the real hammer drops when CMS looks at these 27 never events and says, we are no longer paying for these.
Right.
Yes.
That was the turning point.
So if a surgical team leaves a sponge in a patient, and the hospital has to book an operating room, use anesthesia, and perform a second surgery to extract that sponge, the hospital has to eat the entire cost of that second procedure. They can no longer bill Medicare for the cost of fixing their own horrific mistake.
That policy change was an absolute game changer. CMS is the single largest purchaser of healthcare in the United States. Where CMS directs its capital, private insurance conglomerates like Blue Cross or United Healthcare almost immediately follow.
So the whole industry shifted.
By refusing to reimburse for never events, CMS instantly aligned a hospital's financial survival with its clinical safety record. The theoretical concepts of quality improvement were suddenly tied to the hospital's bottom line. The business case for quality became impossible to ignore.
That is the ultimate stick, but you also need a carrot to drive excellence rather than just punishing the worst offenses. How do they financially incentivize the hospitals that are actively getting better?
The financial incentives evolved significantly during the era of the Affordable Care Act, primarily through the introduction of value-based purchasing, or VBP. To fund this, CMS implemented a mechanism that essentially holds back a portion of the funds that hospitals were historically entitled to receive.
Wait, they just keep the money?
Temporarily. This pool of withheld money is known as the CMS market basket.
I want to make sure I understand this market basket concept clearly. CMS looks at a hospital, calculates what they owe them for the year's services, but then intentionally takes percentage of that earned money and holds it in a separate pot.
That is the basic mechanism. CMS withholds a mandatory percentage of Medicare payments from participating hospitals across the board. Then, those hospitals are rigorously evaluated and scored on their performance across a wide array of quality metrics, things like clinical outcomes, patient experience scores, and efficiency.
Okay.
At the end of the performance period, the hospitals that score highly or demonstrate significant statistical improvement from the previous year get their withheld money back.
And if they don't score well?
They lose it. Furthermore, the high performers receive additional bonus payments. Those bonus payments are funded directly by the money that was withheld from the hospitals that performed poorly.
Oh, wow. Here's where it gets really interesting. It is essentially a high-stakes poker game where the government forces every hospital to pay a massive mandatory ante just to sit at the table.
It really is.
And then it grades them all on a curve. You are literally competing against the rival hospital across town for the exact same finite pot of federal money. It's no longer enough to just be okay or to meet minimum standards. If you are merely average while the hospital down the street is excellent, they are going to take your money.
That completely rewrites the competitive landscape. And that competitive pressure was legislatively intensified. In 2015, Congress passed MECRA, the Medicare Access and CHPI Reauthorization Act. This legislation repealed an older, deeply flawed payment formula called the Sustainable Growth Rate and replaced it by creating the Quality Payment Program, or QPP.
The Waxman text has a very intricate chart detailing the QPP. Instead of just reading acronyms, how does this program actually funnel doctors into different payment structures?
The QPP established two distinct pathways for reimbursing clinicians. The primary path that most practitioners fall into is MIPS, the Merit-Based Incentive Payment System.
MIPS, got it.
The alternative path is for those participating in APMs, or alternative payment models, which involve taking on more collective financial risk. Under MIPS, providers submit data and are scored out of 100 points across 4 specific categories.
What are the categories?
The quality of the care they provide, the cost of that care, specific improvement activities they undertake, and the promotion of interoperability.
Let me guess. Interoperability basically measures how well their electronic health records talk to other hospital systems, preventing a patient's data from being siloed.
Exactly. And just like the hospital-level value-based purchasing, a physician's final MIPS score directly dictates whether their future Medicare payments receive a positive bonus adjustment, remain neutral, or are hit with a negative penalty reduction.
I can immediately see the friction here. Calculating a MERPIS score across those 4 categories sounds incredibly data-intensive. I can hear the collective groan of doctors and nurses who feel like they spend more time staring at a computer screen reporting data to CMS than they do actually looking into the eyes of their patients.
The reporting burden became an immense and highly valid source of industry-wide burnout. Practitioners felt they had been transformed into data entry clerks.
Which is not why they went to medical school.
Exactly. Recognizing this crisis, CMS launched an initiative called Meaningful Measures, and more recently updated it to Meaningful Measures 2.0. The explicit goal was to trim the fat.
How did they do that?
They aimed to reduce the sheer volume of required metrics by roughly 18%, focusing exclusively on high-value areas like maternal health and chronic disease management. Furthermore, the massive initiative for 2025 is the transition to fully digital quality measures, abbreviated as DQMs.
How does a digital quality measure fundamentally change the daily life of a nurse on the floor? What does that look like in practice?
It relies on the deployment of standardized application programming interfaces, or APIs, specifically a framework called FHIR. The goal is interoperability without human intervention.
So automatic.
Yes. When a nurse enters a patient's blood pressure or pain scale into the electronic health record during their normal workflow, that data should automatically be extracted, formatted, and transmitted to CMS algorithms to calculate quality scores.
Oh, that's huge.
The nurse shouldn't have to open a separate portal and manually re-enter that data just for compliance purposes. Meaningful Measures 2.0 also places heavy emphasis on patient-reported outcomes, utilizing specialized measurement tools developed by the NIH to capture how the patient actually feels, rather than just what the lab values say.
The goal is to make the massive data collection machinery completely invisible in the background, allowing the human practitioners to go back to caring for human patients, while the algorithms silently crunch the numbers to determine the federal payouts.
That is the technological ideal. But analyzing this data brings us to a profoundly fascinating and deeply uncomfortable intersection. If we have built an entire economic system designed to pay for value and quality, we eventually hit a philosophical wall.
Which is what?
How do you mathematically, objectively define the value of a specific medical intervention?
Right. We have arrived at the math of human life. When I was reading this section of the chapter, it felt less like health economics and more like a dystopian science fiction novel.
We are entering the realm of cost-effectiveness analysis, or CEA, and the absolute center of gravity in this field is a metric called the QAY, the Quality Adjusted Life Year.
QALY. The QALY. I want to take this slowly and walk through the mechanics because it is really mind-bending. The concept of the QALY isn't actually new. It was created back in 1956 by Condell and McCartney, right? Explain the actual math of how economists assign a numerical value to a human life.
A QALY is a universal measure of disease burden. It is designed to capture both the quantity of life generated by an intervention and the quality of that life lived.
Okay, quantity and quality.
The baseline math is straightforward. 1 year of life lived in a state of perfect, uncompromised health is assigned a mathematical value of 1.0. Conversely, death is assigned a value of 0.0.
Perfect health is 1.0. Death is 0.0. The math seems simple enough so far.
The complexity arises in the space between perfect health and death. If a medical intervention gives a patient additional years of life, but those years will be lived with a significant health burden, perhaps the treatment causes chronic, debilitating nausea, or the underlying disease process requires the patient to use a wheelchair, or they lose their sight, those additional years are not valued at 1.0.
So they get a lower score.
Yes. Health economists use standardized surveys to assign a fractional value to various health states, usually landing somewhere between 0 and 1.
Let's run a hypothetical calculation to make this real. Say a new expensive chemotherapy drug gives a cancer patient an additional 2 years of life that they wouldn't have had otherwise.
Okay, 2 years.
But because of the severe toxicity of the drug and the progression of the cancer, their quality of life during those 2 years is assessed by economists at 0.5. Mathematically, the intervention has provided 1 QAY, because 2 years of life multiplied by a quality score of 0.5 equals 1.0.
That is precisely how the calculation is performed. Health economists and policymakers take that QAY number and use it to determine the ICER, the incremental cost-effectiveness ratio.
And what does the ICER tell us?
The ICER calculates the financial cost of new therapeutic intervention compared to the standard of care, measured in terms of the cost per QAY gained. If a new drug costs $100,000 and yields 1 additional QAY, the ICER is $100,000 per QAY. Policymakers then have to decide what their threshold is. Are they willing to pay $100,000 for 1 QAY? What about $200,000?
I have to pause and push back on this framework because as I was reading about it, my blood pressure started going up. We are talking about economists sitting in a windowless room, assigning a decimal point to the value of living in a wheelchair versus living with a prosthetic limb. This feels incredibly cold.
It is very cold calculus.
Aren't we directly violating the equitable aim of the 2001 Quality Chasm Report by assigning a lower mathematical value to the lives of the disabled? Think about it. If a disabled person and an able-bodied person both need a life-saving organ transplant, and the transplant will give each of them 1 extra year of life.
Under the QLI model, yes, the able-bodied person generates 1.0 QALYs.
Exactly. But because the disabled person's baseline quality of life is pre-assessed at a fraction, say zero point 0.6, the exact same intervention yields fewer QALYs for them. The math inherently argues that able-bodied person is a better return on investment. How does the medical community justify the ethics of that?
If we connect this to the bigger picture, you are articulating the most fiercely debated, agonizing critique in all of health economics. What you just described is the exact argument raised by disability rights advocates, ethicists, and patient groups worldwide.
Rightfully so. I mean, it's terrifying.
They ask profound questions. Is perfect health even a definable, realistic baseline? Does the QALI model inherently and unfairly penalize individuals with chronic mental health conditions or physical disabilities?
Yeah, and what about the people taking care of them? A major flaw of the QALI is that it almost never factors in the immense quality of life impact on the patient's family members or long-term caregivers.
It generally does not.
A treatment might stabilize a patient just enough that their spouse doesn't have to quit their job to provide round-the-clock care. The QALI math completely ignores the economic and emotional salvation of that spouse.
It does. But when analyzing this impartially, we have to recognize the harsh reality that necessitates these metrics. Healthcare resources are simply finite.
Right, there isn't infinite money.
There is not an infinite supply of tax dollars, ICU beds, or highly trained surgeons. The QALI is rooted in a quasi-utilitarian philosophy. If a government has a limited health budget, how do they allocate those finite resources to generate the most optimal, absolute good for society as an aggregate whole?
The classic utilitarian argument, the greatest good for the greatest number.
Correct. Consider the National Institute for Health and Care Excellence, known as NICE, which operates within the National Health Service in the United Kingdom.
Okay, what do they do?
They rely heavily on cost-effectiveness thresholds. This occasionally leads to intense public outcry and media firestorms when NICE decides not to cover a highly publicized, incredibly expensive new cancer drug. The public perceives it as a cold bureaucracy denying life-saving care.
Sure, because there's a face and a name attached to that denied care.
Exactly. But the health economist argument is structural. If the state spends $20 million on a drug that only offers a small cohort of patients a few extra weeks of very low-quality life yielding a minuscule QALY gain, they are mathematically diverting that $20 million away from funding thousands of cheaper, highly effective interventions.
Like what?
Like asthma inhalers or prenatal care.
Yeah.
That could yield massive cumulative QALY gains for a much larger population.
It is the ultimate philosophical trolley problem, just scaled up and played out on a national budget spreadsheet.
It asks the impossible question. Should society prioritize aggressive treatments for severe terminal illnesses out of compassion, even if a cheaper intervention for a milder illness yields a higher absolute utility score?
That's wow.
The QALY metric does not inherently answer the moral question. It simply forces policymakers to confront the brutal mathematics behind their choices.
That is an incredibly heavy reality to sit with. But it leads me to a logistical question. To even attempt to build those mathematical models, to figure out QALYs, or to calculate a hospital's value-based purchasing bonus, or to determine their MIPE score, you need an unfathomable, constant stream of highly accurate data from every corner of the country.
An ocean of data, yes.
Which brings us to the alphabet soup of organizations we encountered in the DuPont glossary. Who is actually building the databases to collect all this information, and how are they structuring it?
There is a famous axiom in quality improvement circles. In God we trust, all others must bring data. It is frequently attributed to Dr. Deming, though, as Hastie points out in his 2009 historical analysis, there was actually zero documented proof Deming ever uttered that phrase.
Typical.
Right. Regardless of the author, the sentiment completely rules the modern healthcare industry. To understand why data is so vital, we have to look at the formula for cost per encounter.
Cost per encounter. That essentially represents the total financial footprint of a patient's stay, from the moment they walk through the sliding glass doors to the moment they are discharged.
Yes. And it is driven by three distinct variables: the intensity of the services provided, the productivity or efficiency of the staff, and the baseline resource prices, such as the local cost of nursing salaries or medical supplies.
Okay, so three dials to turn.
Exactly. If an administrator wants to safely lower the cost per encounter without harming the patient, they have to meticulously manipulate those variables. They can only do that with data. And several key organizations from our source texts supply the infrastructure for that data.
Let's trace how a hospital actually gets this data. Say a hospital administrator wants to know how their complication rates compare to the national average. Who do they look to?
They look to the AHRQ, the Agency for Healthcare Research and Quality. This is a federal agency tasked with producing evidence to make care safer, more accessible, and more affordable.
And what do they provide?
Crucially, the AHRQ develops sets of quality indicators. These are standardized measures derived from hospital administrative data. They include PQIs, prevention quality indicators, PSIs, patient safety indicators, PDIs, pediatric quality indicators, and IQIs, inpatient quality indicators.
Let's ground that alphabet soup a bit. What does an IQI, an inpatient quality indicator, actually measure?
An IQI helps a hospital track things like inpatient mortality rates for specific procedures, like a coronary artery bypass graft.
Oh, okay.
It allows a hospital to analyze their data and realize our mortality rate for this specific open-heart surgery is statistically higher than the national baseline provided by AHRQ. We have a systemic flaw in our process.
And what about the nursing side of the data? Because we talked earlier about never events in the National Quality Forum, the NQF.
The NQF, created in 1999, acts as a primary consensus builder and connector in the quality landscape. They are heavily invested in validating nursing-sensitive care measures.
Meaning things nurses control directly.
Yes. They curate data on outcomes that are directly, undeniably impacted by the quality of nursing care metrics, like the prevalence of patient falls, the incidence of hospital-acquired pressure ulcers, and the frequency of physical restraint use.
So if those numbers are bad,
If those metrics are high, it is a glaring red flag regarding the structural adequacy of the nursing staff. To track this internally, many hospitals subscribe to the NDNQI.
the National Database of Nursing Quality Indicators. This is a proprietary database run by the American Nurses Association, right?
Exactly. The NDNQI allows a hospital to securely upload their unit-specific nursing data and benchmark their outcomes against hundreds of similar facilities nationwide. A critical care unit in Ohio can see exactly how their catheter infection rates compare to a critical care unit of the same size in California.
That is so powerful, but perhaps the most revolutionary database is the one designed entirely for the listener, right? CMS's Hospital Compare, which recently transitioned to Care Compare.
Yes, that one changed everything for the public.
This is the concept that absolutely blew my mind. I immediately compared Care Compare to Yelp or TripAdvisor, but for literal life and death decisions.
It was a radical shift in transparency. CMS took vast amounts of complex data, including clinical outcomes, readmission rates, and data from the HCA-HPS survey.
What's HCA-HPS?
It's a standardized national survey that measures a patient's subjective satisfaction with their care. So CMS took all of this and published it on a public website. In 2016, they simplified it even further by aggregating the data into a 1 to 5-star overall hospital quality rating system.
It is wild to think about the historical contrast. 25 years ago, if you needed a surgery, you just drove to whatever local hospital your primary care doctor told you to go to.
You had no other information.
You were flying completely blind. You had zero idea if that facility had an astronomical mortality rate for that specific surgery, or if their patients constantly contracted staph infections. Today, you can sit in a waiting room, pull out your smartphone, search the hospital on Care Compare, and instantly see their central line infection rates or their patient communication scores.
That unprecedented level of transparency permanently shifted the power dynamic from the institution to the consumer. And ironically, exposing this data to the public also spurred one of the most massive collaborative efforts in medical history. The Institute for Healthcare Improvement's 100,000 Lives campaign launched between 2004 and 2005.
I want to talk about this campaign because in an industry that is fiercely competitive, this felt like a rare moment where everyone put down their swords and shared their secrets.
Prior to this campaign, hospital culture was defined by secrecy. If a prestigious hospital developed a brilliant, innovative protocol that eliminated surgical infections, they often kept it proprietary.
Because it made them look better than the hospital down the street.
Exactly. It was their competitive edge to attract more lucrative patients. The IHI campaign shattered that model. They challenged hospitals across the nation to openly collaborate and rapidly deploy 6 highly specific evidence-based interventions to save 100,000 lives over 18 months.
What were the specific interventions they asked hospitals to implement?
They targeted massive vulnerabilities. First, deploying rapid response teams, highly trained teams that intervene at the first sign a patient is declining on a general floor, long before they go into cardiac arrest.
Yeah, makes sense. Catch it early.
Second, delivering reliable evidence-based care for acute myocardial infarctions, which are heart attacks. Third, preventing adverse drug events through strict medication reconciliation, ensuring a patient's home medications don't lethally interact with hospital prescriptions.
Oh, yeah, if someone is on 5 different pills at home, you need to know that.
Precisely. And finally, they pushed the use of specific care bundles to prevent central line infections, surgical site infections, and ventilator-associated pneumonia.
What exactly is a care bundle? Is it just like a checklist?
It is a small, straightforward set of evidence-based practices that, when performed collectively and reliably, dramatically improve outcomes. Take the ventilator bundle to prevent pneumonia.
Okay, what's in that bundle?
It includes simple, structural steps, elevating the head of the patient's bed between 30 and 45 degrees, giving them daily sedation vacations to assess if they can breathe on their own.
A sedation vacation.
Basically weaning them off the sedation temporarily to see if their body is ready to breathe without the machine. Then providing medication to prevent stomach ulcers, giving medication to prevent blood clots, and performing rigorous daily oral care.
Just brushing their teeth.
Essentially, yes, keeping the mouth clean prevents bacteria from traveling down the tube to the lungs. Doing just one of those things helps a little. Doing all 5 every single time drastically reduces the chance of fatal pneumonia. Thousands of hospitals joined the campaign, shared their data, and proved that democratizing quality could save tens of thousands of lives.
So, if we look at the landscape we've mapped out today, we have the stark moral imperative established by the To Err is Human report. We have the data frameworks. We have the government tying Medicare payments to clinical outcomes.
We do.
But we have to talk about the real-world friction of implementing this.
Yeah.
Running continuous PDSA cycles, building data infrastructure, upgrading electronic health records to interface with CMS APIs, hiring quality analysts, sending nurses to specialized training. All of that requires a massive amount of upfront capital.
It is extremely expensive.
So how does a modern healthcare leader, like a chief nursing officer, walk into a boardroom and justify these immense expenses to a board of directors whose primary legal responsibility is keeping the hospital from going bankrupt?
That conflict introduces the fundamental economic concept of the margin in healthcare quality. There is an inescapable financial reality that higher quality is associated with higher costs, but only up to a certain point. A leader must understand the point of diminishing returns.
Explain how the margin works in a hospital budget.
The margin is the precise point on a graph where spending $1 additional yields less than 1 unit of quality increase. Imagine a hospital with a severe problem with patients falling.
Okay.
The board approves a $1 million budget to hire extra nursing assistants, install bed alarms, and buy non-slip footwear. The fall rate immediately plummets by 50%. That is an incredible cost-effective return on investment.
A huge win.
But to eliminate that last remaining 1% of highly complex falls, the hospital might have to spend another $5 million on futuristic monitoring technology. They have hit the margin.
I see.
The cost of incremental improvement becomes astronomically disproportionate to the clinical gain. Healthcare executives must locate the realistic intersection where acceptable clinical excellence meets sustainable financial viability.
So what does this all mean? When presenting to the board, they also have to calculate the inverse, right? They can't just talk about the cost of improving. They have to highlight the terrifying financial cost of lowering quality.
Exactly. And the cost of poor quality extends far beyond losing a CMS value-based purchasing bonus or paying a regulatory fine for a never event. It includes the skyrocketing premiums of malpractice insurance when errors occur.
Which has to be a huge line item.
It is. Crucially, it includes the rapid depreciation of the hospital's reputation, which is a highly tangible financial asset. If a hospital decides to save money by cutting nursing staff, their clinical outcomes will drop, their care compare star rating will plummet to 1 star, and the lucrative elective surgery patients will simply drive right past their emergency room to go to the state-of-the-art competitor 3 towns over.
So when that nursing executive is standing in front of the board asking for $1 million for a new quality initiative, how do they actually win that argument?
They win by building a bulletproof business case for quality. They must translate clinical excellence into the cold, hard language of the boardroom, using terms like return on investment, cost per encounter, and market share retention. The perfect real-world manifestation of this argument is the pursuit of magnet designation.
I see those massive banners hanging outside of hospitals all the time. A magnet-recognized hospital. What does that designation actually require?
Magnet designation is the highest institutional honor awarded by the American Nurses Credentialing Center, recognizing absolute excellence in nursing practice, leadership, and patient outcomes. Embarking on the magnet journey to achieve that designation takes years.
So I imagine it's not cheap either.
It is incredibly expensive. It requires hiring specialized consultants, overhauling internal governance, funding higher education for nurses, and meticulously tracking immense amounts of data. A financially conservative hospital board will absolutely balk at the massive upfront price tag.
I can hear the CFO now. Why are we spending millions of dollars just to hang a banner on the parking garage?
Which is exactly when the nursing executive reveals the business case. They present the peer-reviewed data demonstrating that magnet-designated facilities experience significantly decreased nurse turnover.
And turnover costs money.
A lot of money. Replacing a single specialized ICU nurse can cost a hospital upwards of $100,000 in recruiting, onboarding, and lost productivity. Reducing turnover saves millions. Furthermore, magnet hospitals have statistically significant decreases in hospital-acquired pressure ulcers and patient falls.
So fewer lawsuits, shorter stays.
Exactly.
Yeah.
That saves millions in non-reimbursed care and malpractice payouts. The executive proves that the massive upfront investment in clinical quality generates long-term, highly resilient financial stability.
The business case must be argued in dollars and cents, but the ultimate dividend paid out by the system is the preservation of human life.
That is the most essential synthesis of this entire topic. The complex math, the QLA-Y calculations, the ICER ratios, the CMS market baskets, the PDSA cycles, they're all just structural economic tools.
Right.
But the final outcome, to return to Avedis Donabedian's foundational theory, is the actual breathing human patient lying in the hospital bed. And the entire system takes on a very different level of urgency when that patient is you or someone you deeply love.
This has been an incredibly eye-opening journey today. We started by examining a broken mechanic analogy, highlighting a historical healthcare system that literally profited from its own preventable mistakes. We saw the terrifying alarm sounded by the "To-Err is Human" report and the 6 vital aims established by the quality chasm.
We covered a lot of ground.
We really did. We explored the minds of the architects, Donabedian and Deming, who taught administrators to analyze structure, process, and outcome, and to relentlessly plan, do, study, and act. We unpacked the immense financial leverage deployed by the government through never events, value-based purchasing, and McCap. We waded through the uncomfortable utilitarian mathematics of QALYs and traced how a single patient's data point flows through the alphabet soup of organizations to enforce transparency.
It is a staggeringly complex, occasionally flawed ecosystem, but the trajectory over the last 2 decades is undeniably moving toward greater safety and accountability.
So for you listening, the next time you go to the doctor for a checkup, or you spend a night in the hospital, and a few days later you get that HCA HPS survey emailed to you, I want you to view it differently.
Don't just delete it.
Right. Don't just delete it. I want you to realize it is not just a digital suggestion box that gets ignored by an office manager. Your answers to that survey are tied directly to federal funding. Your feedback moves millions of dollars through the CMS market basket.
It really does matter.
It dictates the financial survival of that specific hospital. Whether you realize it or not, you are an active, powerful participant in this massive quality machine.
And as we look toward the horizon of how this machine will evolve, I want to leave you with a final, slightly provocative thought to consider. Building on CMS's stated goals in their Meaningful Measures 2.0 initiative.
That's the thought.
Their explicit objective for 2025 and beyond is to deploy artificial intelligence and fully digital automated measurement to identify quality problems before they even occur.
Using predictive algorithms to anticipate a medical error before the nurse even enters the room.
Precisely. It is an incredible technological leap, but it raises a profound ethical question. If we successfully transition to a fully digital, AI-driven quality measurement system, a system where algorithms flawlessly dictate the statistical value of care instantly calculate a patient's QAY potential, and preemptively manage resource allocation, do we risk permanently losing the unquantifiable art of human healthcare?
Wow.
If a cold, highly efficient machine determines that a specific patient's QALY potential is simply too low to justify the cost of an intervention, how will human doctors and nurses navigate that space?
Right.
How will we as a society balance the rigidity of a flawless digital metric against the messy, unpredictable, and beautiful reality of human hope?
We started this hour talking about the urgent need to fix a broken, dangerous machine. And now we are left wondering if engineering a truly perfect machine might inadvertently break our humanity. Thank you so much for joining us on this deep dive into the hidden gears and the high-stakes economics of healthcare quality. Keep questioning the invisible systems around you, keep looking for the why behind the headlines, and we will see you next time.